Good afternoon.
Good afternoon.
This is a great turnout. Wow, fantastic. I'm George Daly. I'm the Dean of Harvard Medical School. I apologize for being late. This has unfortunately become my MO. I had a late meeting, but I'm here and I'm absolutely delighted. I remember our meeting last year, and this is always a remarkable celebration of our community. So we are here because we're going to be celebrating extraordinary recipients of our diversity awards. And I am always inspired by the history of Harvard Medical School and these three individuals whom we honor today. To imagine that these doctors Howard and Dorsey and Still, were graduates of Harvard Medical School, class of 1869 and I think class of 1871. I think it's part of our proud past at Harvard Medical School. And we're going to be hearing a bit more about their careers and their histories from Dr. Joan Reed. I'm also very, very pleased to welcome our distinguished lecturer, Dr. Otis Brawley, who was until recently the Chief Medical and Scientific Officer and the Executive Vice President of the American Cancer Society. We have met previously as I've pitched the American Cancer Society. I can't remember if I got the money or not, but I know there was a big ask at one point in my past. But anyway, Dr. Brawley is now the Bloomberg Distinguished Professor at Johns Hopkins, where he's leading a broad interdisciplinary research effort into cancer health disparities. So thank you, Dr. Brawley, for being here with us today. And I think we are all going to be equally inspired by the recipients of this year's Diversity Awards. Their commitment, their work on behalf of the community has brought meaningful change, and they have clearly shown us how diversity enriches all of our lives and how diversity is founded on the strongest principles of excellence. Right from the beginning, when I first became dean, one of my first phone calls was to Joan Reed, and in part because diversity and inclusion is a very, very high priority. It's one of our most important goals, and we are deeply committed as an institution, as a university, to this work. And it goes way beyond the issues of fairness. It really is about embracing excellence. Actually, in reviewing my comments today, I actually got online and did a little bit more research. And there is a significant amount of social science research and a growing body of literature, some of which my wife, who works in teams, has directed me to. And the idea that when you bring multiple perspectives to teams, the teams function more effectively, they make better discoveries, and they contribute to a greater sense of meaning and satisfaction for the participants of the team. So I'm incredibly moved as I look at this community here to realize how much richer our environment is because we bring an eye towards diversity and celebrating that diversity. Joan, I think, has been a leader in creating a culture that teaches us that diversity and excellence go hand in hand. And because of the dedication and the hard work of the folks today that we're going to be honoring, and I have to say it's not just those we're honoring today, but folks who continue to work tirelessly throughout our community, we've made significant strides. But like so many areas, Harvard Medical School, we can never be complacent. We can never be satisfied with where we are. We have to keep striving to do better. And um, I'm so pleased that we have such great leadership behind Dr. Reed, but I call everyone in this community to work on behalf of the core mission of improving our community, because truly we are better together. So thank you very much. It's my pleasure to turn over the podium to Dr. Reed.
Thank you very much. Good afternoon.
Good afternoon.
Oh, see, some of you know me long enough, you know to respond. You know we just go over and over, we're going to do the same thing. Thank you, Dean Daly, for allowing me to be part of this institution, to be a part of an institution that recognizes diversity and inclusion and respect for all and valuing all as part of its core values. And in 2004, Dr. Nora Nersessian, who is a former Associate Dean for Alumni Affairs here, published a book called Against All Odds. There's copies of the book in the back. If anybody would like a copy of the book, please pick it up. It chronicles a history of what we might call civil rights, affirmative action, diversity at Harvard Medical School going back to 1850. So please take one of the books with you. She covered 150 years of African American presence at Harvard Medical School and really brought to life the lives of Black men and women in medicine and their struggles, their determination, their triumphs. And in this were the stories of Howard, Dorsey, and Still, the first three Blacks to graduate from Harvard Medical School. And a little about them. In 1869, after graduation, Edwin Howard practiced medicine in Charleston, South Carolina, and then later moved to Philadelphia, where he was essential in establishing the Frederick Douglass Memorial Hospital, and that was in 1895, and at the time it was the only hospital in Philadelphia serving African Americans. He then went on to establish the Mercy Hospital in 1905, and here's a quote from him about why he established it. And as I read you some of these things, my hope is that you think about where we are today, how far we've come, and how much this still resonates. The present hospital, the present Frederick Douglass, having assumed the character of a privately managed, narrow, unprogressive institution, fails to meet the objectives for which it was organized, an opportunity for Negro physicians to get the incalculable benefits of hospital practice, which other hospitals had denied them, also to train our girls in nursing, as well as giving our people additional hospital facilities. So even then, there was this awareness of the need for access and for training physicians and nurses of diverse groups. Thomas Dorsey was the first student of African descent to actually earn his degree from Harvard Medical School, and we know very little about what happened with him. We know he settled for a period in D.C., and during that time, there would have been the establishment of Howard University and its College of Medicine. But if we turn to Dr. Still, James Still, he graduated with honors at Harvard Medical School in 1871 and actually settled here in Boston, where he practiced. And part of the reason, the thinking why he might have actually come to Boston was he saw it as an abolitionist city. He was the first African American elected to the Boston School Board and was involved in opening the first African American teachers into Boston public schools. He was a spokesman for civil rights, and it was actually his nephew, William Still, who is recognized as the father of the Underground Railroad. So in addition to paying tribute to these three men, there are many other amazing individuals in our community, and that's who we're here to honor today. And those are for the Harold Amos Faculty Diversity Award and the Sharon P. Claiborne Staff Diversity Award. Just a little bit about Harold Amos, and we have a new video that you have not seen. He was the Maud and Lillian Presley Professor of Microbiology and Molecular Genetics. He joined our faculty in 1954 as an instructor and became the first African-American department chair in 1968. He was also the first African-American individual to earn a doctoral degree from the HMS Division of Medical Sciences in 1952. A lot of firsts. And now Harold Amos.
program at Davis, knew Harold very well. It was difficult not to know Harold if you're a microbiologist, and he was by that time very well established and very highly respected. So he told me, you're going to really enjoy meeting Harold. And so of course, he was right. Meeting Harold at this interview was a delight. He wanted to talk science. He was really interested in my science, but he also said, he looked at me and says, "You look sort of thin. You don't eat enough." And he said, "Don't tell me you're one of these people who does exercise."
I ended up meeting and playing Harold Amos in tennis, and that's how I first met him. He always won. He was a very good tennis player, actually, and he always won. But it was fun playing with him, and it was enjoyable.
As a young scientist just coming out of postdoctoral work, I was offered a job here at the medical school in the bacteriology department, and he was a fellow faculty member. And I arrived, and he was just the friendliest you could imagine. Particularly in those days, I think there was much more stiffness at Harvard, but Harold was not stiff at all. He was incredibly warm and friendly and helpful and welcoming.
Full scholarship to Springfield College in the mid-1930s, unique in its own right, in the service, returned here to get his PhD in the medical sciences, and then establish his own prominent track record in research, but always cultivating students, cultivating young faculty behind himself. So all of his extraordinary life, he was called a jewel in this world.
You know, he was such a humble man. He never would talk about me as the first African American who did my PhD here, who served as faculty member, who was chair of a department. Never. I mean, it was clear that he had done it, and he was very much somebody who wanted to be proactive about the opportunity that was offered to other people in minorities, very much so.
I arrived in '65, and that was a new era, really. I mean, I didn't bring the new era with me, it was there. He certainly became very active during that period, as many of us did, in pushing the medical school to bring in more minority students. There were, on average, one black medical student every 2 years. So it's half a black medical student per year.
It was really the medical people who were very strongly opposed to bringing in the African American students to the medical school, with the argument being that we were going to bring people who were not qualified to the medical school.
So we had to make the argument that, and this is what Harvard likes to hear, is this is a new era coming. If you bring in more African Americans into the medical school, they are going to become leaders in the country, and Harvard always wants to be responsible for determining who the leaders of the country in various fields are going to be. And I remember there was a very serious debate. Some people were very upset or tried to water it down. There was another African American doctor in the medical school who got up at this meeting and said, I can't remember the exact wording, but we don't want to be taken care of by you. We want to be able to take care of ourselves, which really at that point we thought was going to destroy the argument at this debate among the faculty members. And Harold stood up and very gently responded very differently, and that sort of turned to some extent turned the tide in the discussions.
He was the most wonderful gentleman, civilized human being that had a great heart, and his heart was in the right place, and he promoted the educational mission of this university or this medical school. All the directors of all of the programs that would get together, and then each program would present its candidates, and then the big group would then discuss. And he personally took great care in looking at each one of those applications and making sure that nobody was being left behind, that might be very much worth giving an opportunity. Would make sure that they would not be left behind. And I think that was, so rather than being very pushy about it, he did a very gentle way of making sure that they would be considered. Yeah.
So you got to remember that our department was pretty much a basic science department. He wasn't a medical doctor. I'm not a medical doctor. So the students we dealt with most closely were graduate students, not the medical students. But in spite of that, he found students who came into medical school who were African American and worked with them and mentored them.
He was in so many ways and another extraordinary personages within the history of Harvard medicine, a professor's professor, somebody who was also kind, committed, a researcher, an insightful individual, forever looking out for students.
One needs lots of champions of diversity. It's important to maintain that award, and it's important to name the award for the first African-American professor at Harvard Medical School, which had to be an enormous breakthrough.
Quite often these awards, decades after somebody has died, are given and people are happy with the award, but they do not know anything about it. And I think Harold is so special that it's very important that whoever gives the award makes sure that the recipient knows who Harold was. He was a great human, and you can be absolutely honored by the fact that this great human is the name of the award that you receive. And I would hope that you can, regardless of who you are, you can try to emulate that humanity.
So thank you very much. I just want to also add a few words about Sharon Cleaver and the other award, who was the medical school's first financial aid office in 1981 as a staff assistant. That's when she first came. She's received many awards and attention from our students, and actually the class of 1999 presented her with an award in recognition of tireless dedication to the students of Harvard Medical School. She also received the 1998 Young Black Achievers Recognition for her commitment to the service on behalf of young people. She received the first annual Dean's Award for Community Service for working on good news and her gospel program at MIT. We now want to turn to our guest speaker today. When we established this lecture, it was meant to honor these three individuals, but to also recognize others who've made significant contributions to advancing this nation's health. And our guest speaker today is Dr. Otis Brawley, who you've heard is the Bloomberg Distinguished Professor of Oncology and Epidemiology at Johns Hopkins University. We were talking a little bit earlier, he's been on my list of these honorable people like you want to meet one day, and I got to meet him with this award. Maybe that's why we have these awards and lectures, so I get to meet my heroes and sheroes. But he is definitely one of my heroes. He's an authority on cancer screening and prevention, leads a broad interdisciplinary research effort at Johns Hopkins School of Medicine, Bloomberg School of Public Health, and the Sidney Kimmel Comprehensive Cancer Center. He was a member of the National Cancer Institute Board of Scientific Advisors and a member of the National Academy of Medicine. He's held numerous positions, leadership positions such as those in the American Cancer Society, but also was the director of the Georgia Cancer Center at Grady Hospital. He was a professor at Emory University. He was the Georgia Cancer Coalition Scholar. As I said, many other awards. One of the ones that I think is most amazing, special service for his work in the aftermath of Hurricane Katrina. So in service in many, many ways. He's a leader at the National Institutes of Health. He cares deeply about students. He cares deeply about his research. He cares deeply about our patient populations. And with that, Dr. Otis Brawley.
How do I get the?
I will help you.
Yeah, thank you.
It's my pleasure.
Oh, that's what
Yeah,
it is.
they hide it. Sorry about that. And here it is. We'll just do this, and that's the clicker.
Perfect. Thank you.
And your thing's on?
Yes.
Your microphone on.
Yes, thank you. It is truly, truly a pleasure to be here today. Thank you, Dean Reed. Thank you, Dean Daly. A little about Joan Reed. Got to meet her fellows last night and spend some time with them. I've actually known of Joan Reed. I'll actually say I'll probably get in trouble for this. Known of Joan Reed for 30 years and never really got to meet her. I've heard her talk. As I travel around the country, she has a national and really international reputation for her work in diversity and her work in creating leaders and guiding people. And it's just wonderful to finally get to sit down and have a conversation with you. In many respects, I sort of feel like the Forrest Gump of medicine, and that I get to meet people like you and get to have, I, by the way, got to meet Harold Amos about 30 years ago. It was in the early 1990s. Also, today is a very, very special day for me because as we talk about diversity, opportunity, mentorship, and encouragement are all incredibly important. And it was 39 years ago that Dr. Elliot Keith and his wife, Jacqueline, met this 19-year-old wet behind the ears kid from Detroit who was at the University of Chicago. And they spent a lot of time counseling him against going into graduate school in chemistry and toward going to medical school. And Elliot and Jacqueline, thank you very much, and I hope I'm paying it forward. Now, Michael Bloomberg has given me a tremendous opportunity at the Johns Hopkins Medical Institution to sit back and sort of look at what's going on in oncology, look at what's going on in medicine. And for the next half hour or so, let's talk a little bit about cancer control in the 21st century and the emergence of the field of cancer health disparities and what's really going on. First, my disclosures. I work for Johns Hopkins. I do some consulting for the government, do a little bit with Turner Broadcasting. Those of you who have seen me on CNN know that some producer at CNN decided that one way to make Sanjay Gupta look really pretty is to put him on TV with me, and then the contrast between the two of us. I published a best-selling book a few years ago reflecting on what's going on in medicine as well. So let's talk about cancer control in the 21st century, and let's reflect a little on the evolution of the field of health disparities, cancer mortality trends we'll go through, look a little at the economics of healthcare, both in cancer and in general, and then end up talking about the future of healthcare. Now, a brief history of the discipline of health disparities. Coming out of the civil rights movement in the 1950s and 60s was the realization that there were black-white differences in the cancer death rate as well as in cancer survival. And then there was increasing awareness of sickle cell disease as well. And those things actually led to an interest in what was called minority health throughout the 1970s. And it evolved and people started calling it special populations health. And then I was actually an admiral's aide working for Surgeon General Satcher in the room when I think he actually first came up with the idea of calling it health disparities. He literally said, we were talking about how to get special populations research or minority health research accepted in the political community. And he said, let's call it health disparities. And I want to see a politician stand up and say, I am against programs to reduce disparities in health. That's literally how it started. Now we're starting to talk about health equity. Now, a little about cancer. My old group at the American Cancer Society estimates that about 1.8 million will be diagnosed with the disease this year, and about 607,000 will die of the disease this year. I'm going to show some age-adjusted cancer mortality rates in a little bit. But since 1991 going to 2016, the last year we have data, there's been a 26% decline in cancer mortality. Here you can see in 1900, for every 100,000 Americans, 64 died from cancer. In 1991, it peaked at 215, and now it's at 159 as of 2016. That 26% decline over 25 years. Now, when we talk about cancer disparities, we can actually talk about them by race, by location, by socioeconomic status. A little bit about race. The demographic data that we have falls into these 5 racial categories and one ethnic category, Hispanic or non-Hispanic. The federal government only recognizes 2 ethnicities, Hispanic and non-Hispanic. These categories change every 2 years before the census. Indeed, when we talk about changes, it means that they are socio-political categorizations and not biologic. They've been rejected by the anthropologic community as being non-scientific. When I say it changes over time, if you talk about Native Hawaiians, when the Republicans control the White House, Native Hawaiians are considered Pacific Islanders. When the Democrats control the White House, Native Hawaiians are considered Native American. If you know someone who's from India who came to the United States prior to 1950, they've been 3 different races in their lifetime. They were actually considered Caucasian in 1960. If you know where the Caucasus Mountains are, that actually makes a little bit of sense. And my favorite of all time is Barack Obama was white in 1970 and became black for the 1980 census. The 1970 census had a very Judaic definition of race. It said you should declare yourself to be the race that your mother considers herself to be. So it's socio-political. It is not based in biology. Now, disparities by location, we're going to talk about some disparities by region in the United States, state, north, south, east, west, rural, urban. We're going to talk about neighborhood. One of my friends likes to say your zip code is more important than your genetic code, which is true. Socioeconomic status is also a way that we can look at disparities, and we'll talk about personal income, family income, education, and so forth. I'm sorry, I trained in both medical oncology and epidemiology. I have to keep showing you these graphs. If the lines go down and to the right, that's good. If the lines go up and to the right, that's bad, okay? This is 1990 to 2015, looking at mortality from cancer by those 5 racial categories. You can see blacks on top, who have the largest decline, whites in orange, and then Native Americans who've had essentially no decline from 1990 onward. The noise is because the population is very small. Then you can see Hispanics as well as Asian Pacific Islanders. Everybody's in decline except Native Americans. Blacks have the greatest decline, but they started at the highest level. Now, the American Cancer Society estimates that of the 1.8 million who are diagnosed this year, 202,000 will be black or African American. Of the 607,000 who will die, about 72,000 will be black or African American. While we've had a 26% decline in 25 years for the population as a whole, we've had a 35% decline for blacks. That's just saying that that blue line is going down faster than all the other lines. This is looking at our history from 1975 onward for breast, colorectal cancer, and prostate cancer. Colorectal cancer divided up between male and female. I want you to see a pattern in breast and colorectal cancer. There were no disparities by mortality in the 1970s, and the disparities only started around 1980, and you can see they get wider and wider, and indeed in breast cancer, the death rate disparity in breast cancer is greater in 2015 than it has ever been. Again, it did not exist in 1980. Same in colorectal cancer. You can see the scissoring for men and women here. This is what the disparities have been about for blacks and whites, and quite honestly, we should be talking about the white disparity versus the other races and ethnicities. There's a lot that can be learned there. And then prostate cancer is a special problem, but you can see we've now got declines in mortality in prostate cancer. Now, population disparities have always increased when there's scientific progress in medicine. In the 1970s, we learned how to screen and treat for breast and prostate cancer, and then we created those disparities between blacks and whites because of progress. And this has been seen whenever there's improvements in screening and treatment of disease. And it's going to occur even more as we move into the era of precision medicine and immunotherapy, where some of the drugs actually are starting to work very well. And new preventive interventions, by the way, are less likely to cause disparate outcomes. There are no disparities in smallpox. We can prevent that disease. Looking at breast cancer, in 2019, it's estimated 269,000 will be diagnosed, slightly more than 42,000 will die. There has been a 40% decline in age-adjusted female mortality from breast cancer from 1990 to 2016. A 40% decline in mortality. This is really that same graph I showed you earlier for women. This is blacks in red, whites in blue, and these are the other three races and ethnicities here. And you can see again, there was no disparity in the 70s, the beginning of the disparity in the 1980s. We really started learning how to screen and treat for breast cancer in the early 70s, and people started not dying around 1980 or so. Now, showed you black-white disparities over a period of time. Let me show you the disparities over a period of time by state. This is not by race, but this is by state. The dark blue states, you can see primarily in the Northeast and in the very north, are the places where there's been up to a 51% decline in breast cancer mortality over the period 1988 to 90 through 2015. The purple states are the states that have had a 20 to 29% decrease in mortality. Literally, a woman who lives in Massachusetts who is 60 years old today, her risk of dying from breast cancer is half what a woman of the same age, her risk of dying from breast cancer in 1990. Her risk of death has halved over 25 years for a 60-year-old woman of any race, any age. However, for a woman who lives in Louisiana, her risk of death has gone down by 20%. Not 50%, but 20%. That's a disparity by race. This is not, disparity by state. This is not a race thing. This is a state thing. There are 7 states, by the way, in the United States where there is no longer a black-white mortality difference. Now let's look at colon and rectal cancer, colorectal cancer. 101,000 will be diagnosed with colonic cancer this year, about 44,000 with rectal cancer. 51,000 Americans are going to die from colon and rectal cancer. There has been a 50% decrease in colorectal cancer death in the United States since 1980. That is to say, a man or a woman who is 60 years old today, their risk of dying from colorectal cancer is half what it would have been for a 60-year-old in 1980. That's real progress, true progress. This is looking at it in race for women. Again, you can see black women, white women, and the other races and ethnicities here. By the way, we only started counting deaths for the other races and ethnicities in 1990. This is men. Again, you see the scissoring. This is looking state by state. These are in blue up here in the Northeast, you can see 63% decrease in risk of death from colorectal cancer for men in Massachusetts. In Mississippi, 12%. Again, we're starting to define disparities not by black-white, but by Massachusetts, Mississippi, by state, region of the country. As a matter of fact, if you were to, it's a 50% decline overall in the United States. If we were to remove the old Confederacy, the decline would be almost 60% in the United States as a whole. Now, insurance matters. Sorry, this is a little bit more complicated than I would like, but this is 5-year survival. You can see 60 months on the x-axis. And this is percent. 0.9 is 90%, 0.8 is 80%, and so forth. Stage 1 is in red, stage 2 is in blue. The insured are solid lines, and the uninsured are dotted lines. These are really people who are uninsured or have Medicaid that they get when diagnosed with colorectal cancer. And the purpose of this slide is just to show you that in the United States of America, you are better off having stage 2 colorectal cancer with insurance than stage 1 colorectal cancer without insurance. Your chances of surviving 5 years of colorectal cancer with the more advanced disease is better than your chances of surviving 5 years with the less advanced disease. This is simply to tell you insurance matters. Now, causes of colorectal cancer disparities are differences in the prevalence of screening, the quality of screening. We don't talk enough about quality of screening and treatment. The proportion treated, quality of treatment I've already noted. There are differences by race and socioeconomic status, but there are also differences by region of residence. I'm a cancer doc. I can't give a cancer talk without talking about lung cancer, the leading cause of cancer death in the United States. The dark states here are the states that have the highest death rates from lung cancer, and the light states have the lowest death rates from lung cancer. You can see in Kentucky, the death rate is 67.7 deaths per 100,000, whereas in California and Utah, the death rates are about 19 per 100,000. A difference, 19 versus 67. Now, smoking rates are very high still in these red states. Remember, this actually reflects what smoking was like 30 to 40 years ago. It takes 30 or 40 years of smoking in order for somebody to die from lung cancer. So these death rates reflect what smoking was like 30 or 40 years ago. But quite honestly, if you looked at smoking rates, they'd be very similar today. The heaviest states in the United States for smoking are Kentucky and West Virginia, where almost 30% of adults smoke. And the lowest states are Utah and California at about 10%. I guess when I talk about smoking in California, I have to stress it's 10% smoked tobacco, right? And by the way, when we look at states, the death rate from Utah is 125 per 100,000 in 2015. The death rate in Kentucky is 195 per 100,000. Huge disparity, not by race, but by state. A lot of this has to do with smoking, and a lot of this has to do with other preventive activities. Indeed, I think the most important question we can give in cancer control is how can we provide adequate high-quality care to include preventative services to populations that so often don't receive them. This is a very busy slide, but just for a second, focus on this column and this column. Smoking, 33% of all cancers are due to smoking. The combination of overweight, diet, and lack of exercise account for 25 and 30% of cancers. Second leading cause of cancer in the United States, think of it as a three-legged stool. Energy balance. It's too many calories, not enough exercise, and obesity. Second leading cause of cancer in the United States. And then, of course, we have occupational factors, viruses, alcohol, UV radiation. I spend a lot of time in the screening space. One thing that we don't admit to ourselves a lot is right now, nearly 2% of all cancers in the United States are actually due to medical radiation. When we talk about questions of screening for mammography or for lung cancer screening, so forth. We need to think about that. 2% or so of all cancers in the United States are now due to medical radiation. Tobacco is still the leading cause of cancer and cancer deaths in the United States. Cancers due to tobacco use, however, other than bladder cancer, are actually declining, more so in men than in women, but they're declining in both men and women. Cancers caused by infection are a significant problem, and we can do a great deal to prevent those cancers. Liver cancer deaths are expected to go up 50% due to HCV and HBV. Now, hepatitis C is one of the few viral illnesses that we can cure. And unfortunately, the cure cost a mere $50,000. That's cheap in my world. I routinely give drugs that cost $150,000 to $200,000 a year. But the cure for hepatitis C is $50,000. Unfortunately, the people who get hepatitis C are the very people who cannot afford the $50,000 cure, and they very frequently live in states that are not willing to pay for that $50,000 cure. Hepatitis B is preventable with a vaccine. Head and neck cancer deaths are increasing by 30% in the near future due primarily to the human papillomavirus, and HPV in the long term is also preventable with a vaccine. Prevention of cancer is clearly a need in the future and something that needs to be on the agenda for the 21st century, as does energy balance. Overweight, obesity, and too many calories, lack of exercise. 2/3 of adults in the United States and 1/3 of children are overweight at this time, and weight-related cancers are expected to increase 30 to 40% within the next decade to 12 years. We've gone from 5% of kids being obese in 1970 to 20% of kids being obese today. Weight-related cancers are something we really need to look at, especially in the United States. This is the United States in 1970 with the less than 15% of adults being obese. Now we're well over 30%. These are some of the favorite countries I like to compare the U.S. to. You can see the obesity problem is a uniquely American problem, although it is starting to catch up in other countries as well. This is the problem in non-Hispanic Black women. Today, nearly 60% of non-Hispanic Black women are in the category we would call obese. That is not obesity plus overweight, that is obese. And it's a problem for all Americans in general. And it's a lifestyle issue. There are a number of things that are going on in American culture that encourage us to be overweight and obese. And that's a social science, social medicine issue, but it is something for the agenda for cancer control in the 21st century. And this is oh so important as we talk about the cost of health care in the United States. I'm going to show the last few slides talking about what this is costing us. This is what the U.S. spends on health care on a per person basis from 1980 through about 2010. And you can see the rise in the United States versus other countries that we like to compare ourselves to. Our health care costs on a per person basis, per capita basis, is going up dramatically. In 2016, we spent $3.3 trillion on health care. That's not 3.3 billion, that's 3.3 trillion. A trillion is a big number, okay? 1 million seconds ago was 11 and a half days ago. 1 billion seconds ago was 31 years ago. Ronald Reagan was president. 1 billion seconds ago, and 1 trillion seconds ago was 32,000 years ago. 30,000 years before Jesus Christ was 1 trillion seconds ago. 1 trillion is a big number. We spent $3.3 trillion on health care. Another way of looking at it, these are the largest economies in the world. If American health care were its own country, it would be the 5th largest economy in the world. We spent more on health care than was spent on everything in the United Kingdom, and we damn near spent as much on health care as was spent on everything in Germany, the fourth largest economy in the world. We spend a lot of money on health care. $3.3 trillion translates into almost $10,000 per man, woman, and child in the United States. $3.3 trillion translates into almost 18 cents out of every dollar spent in the United States was spent on health care in 2016. How does that compare to other countries? This is cost per person versus life expectancy. And you see the United States up here is the most expensive cost per person. This is 2013 data. And you can see all of these countries, people live longer and healthcare costs less. Switzerland is the second most expensive country in the world, but people in Switzerland live much longer. And I was actually at the University of Nebraska last week and at the Buffett Cancer Center, so I had to pull this quote into the talk. Cost is what you pay, value is what you get. We pay a lot in the United States and we get a lot less than what other people spend. We can become much more efficient than we are in terms of health care. If we were Switzerland, health care in the United States would be far less expensive. One of the things a chief medical officer has to do is help negotiate insurance for your employees. When I was at the American Cancer Society, we had 5,000 employees. Every year or two, you had to negotiate what health insurance costs. The average cost of a health insurance policy for a family in the United States right now is $18,500. If we were Switzerland, it would be $11,600. We would have higher productivity and employers would be able to employ more employees. And costs are actually going up. Actually, one of the most frightening graphs I've seen recently, and I should incorporate it into the talk. It actually looks at median family income starting at 1960, going through 2015, and projecting onward. And it looks at average cost of a healthcare policy starting at 1960, going through 2015, and projecting onward. And the two lines cross in 2040. That's not possible. Median family income and average cost of a health insurance policy the same in 2040. It actually means we are going to have healthcare reform. Whether the politicians want it or not, we're going to have healthcare reform. See, one of the problems that we have in American medicine now is that some people overconsume resources, and this can be harmful to the overconsumer. People actually die because of medical interventions that they didn't need. Some people underconsume. This is the cause of many of the disparities. We need to get good medicine in Louisiana and Mississippi, for example, both preventative and therapeutic, meaning healthcare outcomes could be better and actually at a cheaper price. This is a plea for evidence-based medicine. There's huge inefficiencies right now in the overuse of medical technologies, and it's perhaps best seen in what's happening in screening for cancer. There is good evidence-based screening to do all of these things, but very frequently these things are being done in an inappropriate fashion, either too often or in the wrong populations or the wrong types of tests and so forth. Now, the true cost of American health care to a cancer doc like me. I told you earlier that my group at the American Cancer Society estimates that 600,000 Americans will die from cancer this year. It's also a fact that college-educated Americans, the 32% of us who have college educations, have a much lower risk of cancer death than the other 68% of the American population. We simply calculated how many people would die this year if all Americans had the risk of cancer death of a college-educated American. This is not new science. This is not a new screening test, not a new treatment. This is simply if all Americans got what we already have and we already know a human being ought to be getting from the prevention standpoint, the screening and treatment standpoint. The answer is, instead of 607,000 deaths, there'd be 455,000 deaths. Literally, a quarter of all cancer deaths would be preventable if we just distributed what we already have to everybody in the United States. 152,000 deaths a year, a quarter of all the cancer deaths. Actually, the number would be even higher if we started talking about diabetes and cardiovascular disease. The 152,000 deaths per year that are preventable, by the way, the majority of those 152,000 people call themselves white. Health disparities just became an issue that is beneficial to all Americans regardless of race, more beneficial to the white population than the black population or Native American population or others. The issue of disparities in health is no longer just a racial minority issue. And so, I'm hoping that I've convinced you we need to start talking about health equity, not just equality. How do we get the services that people need to the people who need them? And this slide is just making the argument. Some populations are going to need a little bit more than others. I would argue that we need to be doing a lot more in Louisiana and Mississippi right now than perhaps in Massachusetts. And so I'm actually going to stop at that point. It has been a true pleasure to be here, and I'm really thrilled to meet you guys. And I don't know if we have time for questions or not. Yeah, we have time for a couple questions. Thank you.
Question or comment?
I think this is being recorded. Yeah.
I didn't know. Now I'm shy. But one comment is in the states that they have the increased rate of cancer in the southern states, it seems that economically, probably they are poorer states in comparison to the other states. So I would suspect it's not just location and culture, but it's socioeconomic.
It is socioeconomic. The states that have the worst outcomes, it's really a socioeconomic thing, using socioeconomic in its broadest sense of the word. Those are the states that have the lowest family incomes. They have the greatest distances to health care. They have the lowest levels of high school and college graduation. And another socioeconomic issue, those are the states that have not expanded Medicaid in the Affordable Care Act. So there are a number of issues that make those states being in the back of the pack in terms of outcomes. Anybody else? Well, thank you very much.